most of the patients we see with non-small cell lung cancer do not have driver mutations. And so our decisions in that setting, in the metastatic setting, are really driven by histology. So that's why it's important to have a good sense of what the histology is. In the non-squamous, which is largely adenocarcinoma population, we tend to use in good performance status patients doublet platinum-based therapy. And I think the two sorts of regimens we typically use are carboplatin paclitaxel or carboplatin pemetrexed. One of the considerations is the use of bevacizumab. And I do think that that's an option for selected patients. And I do think that's important if a patient is eligible that they be offered the choice of bevacizumab. It's unclear that using bevacizumab either with carboplatin paclitaxel or carboplatin pemetrexed is superior. We do have the point break data that essentially showed equivalent overall survival, although there was a modest, statistically significant, relatively clinically underwhelming difference in PFS and no difference in overall response rates. Difference in toxicity profiles, the variable paclitaxel versus pemetrexed, these drugs are different. They have different toxicity profiles. The one thing that's nice about having the point break data, this was 1,000 patients randomized between these two regimens, showing absolutely no difference in survival, but differences in toxicity. So you can talk to patients who aren't going to participate in clinical trials, who are getting standard therapy, about what are the toxicities that are most bothersome to them. Many patients would prefer not to have alopecia. So we know that using pemetrexed is associated with substantially less alopecia, and you have the same survival outcome. On the other hand, pemetrexed, you know, it's a more toxic drug in the setting of renal dysfunction, so that's a consideration. Paclitaxel may have an advantage there. It's associated with fatigue, more anemia, more thrombocytopenia. So there are differences in toxicities, and you can kind of get a sense from patients, you know, kind of what sort of experience, if you will, do they want from that sort of thing. And remember, pemetrexed also is a drug that's indicated in the second-line setting, as well as maintenance. So, you know, pemetrexed is a drug that has much more flexibility associated with it, and one can give it over multiple lines of therapy. And so, you know, I do personally believe in my practice that every patient with adenocarcinoma should be exposed at some point to pemetrexed, but I'm not necessarily convinced that it has to be first line. It could be maintenance, it could be second line, but I think since it is an active agent, particularly in the adenocarcinoma population, that they should be treated with it at some point. The squamous is a bit simpler. Our choices there tend to be between taxane versus gemcitabine-based doublets. In squamous, because of efficacy reasons, we don't use pemetrexed, and because of safety issues, we don't use bevacizumab. So our choices are less. There was a randomized phase 3 trial comparing solvent-based paclitaxel to nab-paclitaxel paired with carboplatin that met its primary endpoint of showing a superior response rate, particularly in the squamous histology subset of patients. So the combination of nab-paclitaxel with carboplatin was superior in terms of overall response rate. Now, we did not see a difference in PFS, or a significant difference in PFS or overall survival in that trial. But I'm okay with that in the sense that one thing we know about overall response rates, they don't necessarily always correlate with survival endpoints, but they do tend to correlate with symptom relief. And many of our patients are symptomatic. They have disease-related or generalized symptoms, cough, chest pain, shortness of breath, generalized malaise, fatigue, those sorts of things, poor appetite. And that if you can induce a response more often, they're going to feel better and be palliated with regard to their dominant symptoms. So I think there is an argument for nab-paclitaxel in the squamous population of patients because of this observation of a difference of a 26% response rate with solvent-based paclitaxel versus a 41% response rate with nab-paclitaxel. So that's a consideration in my mind with regard to choosing in the squamous subset of patients. In the non-oncogenic driver setting, where we're trying to make decisions about chemotherapy, optimization of chemotherapy, use of bevacizumab, we know that we want to treat patients first line. We're trying to induce a response or prevent progression, make an impact on symptom relief, and have a net gain in quality of life, if you will. That typically happens within the first 2 to 4 cycles. And then in those patients, the question becomes, what do you continue on, say, beyond 4 cycles? And this has been studied fairly well over the past decade or so with the concept of maintenance therapy. Not a term I love, but to me, it's more either sequential or prolonged duration therapy. Obviously, the initial maintenance trials, interestingly, were done with the drugs that were approved as effective second-line agents. So you could make the argument that this is really using second-line therapy earlier and using it in patients who don't progress during the first 4 cycles. So presumably, those are the more treatment-sensitive patients. And we know that so-called maintenance therapy is a mechanism to improve survival. The 2 drugs that we tend to use in the first 2 to 4 cycles are bevacizumab and pemetrexed, and those are the ones that we typically practice continuation maintenance, if you will. Now, what's a little unclear at the current time is if you're using, for instance, the carbo-pemetrexed bevacizumab regimen, do you need to continue both drugs as maintenance, or should you perhaps continue one or the other? I guess if you're in the decision-making process of one or the other, I might choose bevacizumab as monotherapy because, Bev is what I consider a first-line decision. You use it in first line. It's indicated to be used until progression, so as maintenance. And once you dismiss it, so to speak, you can't go back to it. Whereas, as I previously mentioned, pemetrexed is a drug approved in the second-line setting, and you can certainly reinstitute pemetrexed if, for instance, a patient has been off of it for 4, 6, 7 months or so. You can go back to it. So that's a consideration. We've evolved into having data, certainly in the first-line setting, maintenance second, and if you include the erlotinib data in BR21, it would be the third-line setting, that these therapies can alter the survival of patients with advanced non-small cell lung cancer. So I think part of the art of treating lung cancer is ensuring that patients get multiple lines of therapy in a disease setting that can be a real challenge. Lung cancer is a very difficult disease. Patients have disease-related complications, pathologic fractures, new brain metastases, post-obstructive pneumonia, and these take a huge hit on patients, and so their performance status over time tends to degrade, and therefore it becomes more difficult to treat them second, third, fourth line, and that's why we see a drop-off of the use of the percentage of patients getting second, third, fourth line because of these disease-related sorts of events. And in fact, that's part of the reason why I think maintenance was effective, because it exposed patients to another line of effective therapy relatively quickly. But I think this is how lung cancer has transitioned, even in my very short career. When I trained as a fellow, I was trained that lung cancer is kind of a one-and-done disease. You gave them platinum-based doublets or triplets, and that was pretty much it. We had no evidence that doing something beyond that helped patients. And now we have evidence that multiple lines of therapy can make an impact on survival and symptom management and quality of life and those sorts of things. So it does make a difference.